and a very good evening. Thank you for joining us today. Today's webinar. It is our 18th webinar, and which is organized by our Department of Psychiatric Social Work, RINPAS, Ranchi, Jharkhand. And I firstly introduce myself. I am Nazish Fatima. I did my MPhil in psychiatric social work from Ranchi RINPAS, and now I am currently busy pursuing my PhD degree from Jamia Milia Islamia, New Delhi. And today we are our topic of presentation is self harm behavior among adolescents and the young adults. So here is the brief introduction to the topic, or you can say the mental health. So we can know that the mental health includes our emotional, psychological, and the social well-being. It affects our what we think, what we act, and what we feel. Mental health is important in every stage of our life. It's whether it is childhood, it is adolescent or adulthood. So mental health is very important for us. We focusing today on the adolescent age because this self-harm behavior is very pattern, is very common. 50%, you can say the roughly data that 50% is common in the adolescent children, and other problem that is related to the substance use, school going problem, injury, behavioral problem, and all these leads to the adolescent mental health disorders. So today we can also discuss these some points. I briefly introduce that what is self harm behavior among the young adults, and what is the types of self harms, and how to deal with the self harm, and what do people do in self harm, and what is the possible recovery for the self harm. So participating members can send their questions in the chat box, and we can discuss it later after the presentation. And active participation of all the members is important in this series. And we we request all of you to please choose your mute box, because we can clearly listen to the speaker. And moving to the webinar, I welcome my respected teacher, Dr. Manisha ma'am. She is associate professor and department of head in psychiatric social work department in Ranchi RINPAS. And I have not more words to describe her experience and teaching experience in both in research and teaching, because she has 23 years of experience in this mental health field. So it's over to you, ma'am.
Thank you, Nazish. Thank you very much. I'm really thankful to all my alumni. Before I go to the speaker and the topic, I would really thank all my alumni of our RINPAS, whether of both the departments, rather all the three departments, that who have come forth in running this program so smoothly every week, every weekend. I'm really thankful, and I express my gratitude to each and one of you all. Okay? And for today's topic, definitely it's a very relevant topic. I won't take much time, as Divya will be giving a very wonderful deliberation on this topic itself. And since it's a very significant topic, significant issues that is challenging our mental health professionals, and we are getting cases from adolescents, this particular age group, and it's really very challenging how to overcome all these things. So instead of going into intervention in later phase, what are the things that we can really do in early stage identification and preventive part? That would be really very helpful, that all the professionals, those who have joined today, they can get benefited and they can utilize this information in their professional career. because really, if you want a healthy society, we need to start working into the foundation stone itself, and the youths and adolescents are the ones whom we need to really nourish well, so that all these challenges are not there in the society. So, with these few words, I really would like to thank Divya Prashad. She was our very wonderful student and an alumni of CPE, sorry. And she did her MPhil from RINPAS, and I think PhD also she did it from RINPAS, and a most disciplined and dedicated student whom we had, and we remember her. That means there was some thing that she has given us to ponder, that yes, her discipline and sincerity was of there's no words which can be this can describe about her. Thank you, Divya, and we are very happy that you're doing wonderful in your professional career and other family ways also. So I'm very happy that you're well settled and really working towards promoting this professionals and taking the flag forth, of RINPAS.
Thank
I'm
you.
very happy and thank you very much for giving your consent. We're moving forward. And then Naziz, or you also, for joining us from US in this morning with your all other roles and responsibilities and moderating the session. Thank you so much, Naziz. She was the only, as I already said, that she was the only sole student in the department in her batch, and I could see her loneliness, and then getting my feedback often. It was very hard for her to go through those challenges with me also, that but she balanced between all those things. Thank you, Naziz, for giving your
Thank you,
consent
ma'am.
and moving forward towards you, to you, Naziz. Can you take start the program? Thank you so
Yeah,
much.
firstly, I want to introduce our speaker. She is Dr. Vidya Prasad, and she awarded degree of PhD in 2013 in clinical psychology, and she is pursuing her full time. She is licensed clinical psychologist, and she is doing private practice in Lucknow, and she has almost 12 years of experience in this field. Her areas of interest are borderline personality disorder, emotional issues for adolescent and young adults, cinema and mental health. Other than this, in research area, she has many research papers like Royal Australian and New Zealand Congress of Psychiatry 2016 at Hong Kong, and SARC 2017, Kolkata IACAM 2019, Chandigarh. And it's over to you, ma'am.
Okay. Thank you, ma'am, for giving me an opportunity to speak at my mother institution. And it is always, the past good old days get reminded. Okay. And thank you, Sajish, for the introduction. I would move
Thank you.
forward on talking on my major area of interest, which is self-harm behavior in adolescent and young adults. I hope my voice is audible.
Yeah.
Yeah, yeah.
Now, I've been allotted 40 minutes to 45 minutes to speak, and my talk would be ranging on what is self-harm behavior, what are the types. I would be discussing the types that I have seen in my clinical practice over the years, whatever cases I have got. The reasons why the individual indulges in self-harm behavior, and then how to go about it. That is, how to conduct the therapeutic intervention with people who are indulging in self-harm behavior. And lastly, and most importantly, the pearls and the perils. That is, the do's and the don'ts of talking with people who are indulging in self injurious acts. In between the talk, I would also be throwing light on how to take a history when a case of such kind is referred to you in the OPD or wherever you are practicing as a professional. Now, self harm behavior is not a new concept at all. If you read ancient literature, even the biblical literature, you'll find mentions of self harm behavior. As in one story, an old man is seen cutting himself, possessed with demons, and cutting himself with stones. And then later, Lord Jesus, saves him. So you can very well imagine this mental health concept does have a mentioning in the Bible as well. Now, what is self harm behavior? Now, self harm behavior is an act of injuring or harming oneself with not an intention to die, but to alleviate meaning to reduce psychological pain, psychological distress, and to some extent to regain that emotional balance that the individual feels has been lost. Now, how common is self harm behavior? Now, self harm behavior is very common. It usually occurs in adolescence, in early adolescence, ranging from age 13 years to 15 years, and it progresses towards adulthood. Interestingly, when you will be talking with adults who are harming themselves, you'll find their roots are in the childhood. So maybe the pattern of harming oneself has changed, but the very nature of the problem remains the same. Now, it is also strange that more girls, young females, report self harm than in comparison with the male counterparts. Now, what are the types of self harm? The literature is full of varying kinds. But in my professional experience, I have seen children and adolescents presenting with cuts on their wrist, slashing of wrist, banging the head on the wall repeatedly. This was frequently seen post the lockdown phase. A lot of young females had presented with banging their head on the wall, then burning their arms and wrists with cigarette butts. This is also becoming very common. Overdosing of their own medication or medication of the other family members, consuming poison, phenyl, or other poisonous substances. And one of the most interesting case that I had encountered was a 16-year-old girl who presented with intricate carving on her wrist. It took me several sessions to understand the entire meaning behind the carving, because she was very guarded about the design that she had made on her wrist. And after several sessions, it was discovered that it was done by a compass, which was an everyday implement that she would keep in her bag. So every individual has his own way of harming himself or herself. So literature is varied, but these are the typical types of self-harm behavior that we encounter in our clinical practice. Even pricking the skin of the finger or pricking your thighs and the legs, that is also considered to be self-harm behavior if it leads to severe bleeding of the peeling and bleeding of the skin. Now, we next move forward to that how will you proceed in talking to an individual when you are in your office, when you are in your OPD, and an adolescent comes and is referred to you for case history. And the very moment he divulges to you that he has been harming himself or herself. So, how are you going to take the history? Now, if you clearly remember in our psychiatry and clinical psychology textbooks, it's written that the interview begins with the patient entering your room. So, whenever an adolescent, all covered up, the arms are covered and the buttons of the shirt are, buttoned up, suspicion should arise in your mind that what is he covering up? So many a times you have to be very observant on the general appearance of your adolescent client. When he divulges to you that he has been harming himself or herself, then begin with the circumstances that led to the self harm. What were the triggers? What were the factors? What was the situation that was lurking in his home or in his school or in his other environment that led him to take the decision of, choosing to harm himself? Take him back to that situation. Ask him that what was happening in the home? What was the surrounding? What led him to choose this behavioral pattern? And children and adolescents do speak up when you start with open ended questions. Gradually start exploring the emotions and the negative automatic thoughts that are lurking behind this very problematic behavior. When you get an opportunity to talk with the parents, start with questions such as, did they notice any change in the way they were dressing up? Did they notice any fresh cut or wound on the child's arms or legs? Did they notice any change, any marked change in the patient's eating pattern, appetite? Was he not eating, had reduced eating? Because many a times we also see that not eating or marked reduced, deliberate reduced eating also at times is used as a self-harm paradigm by the adolescents. Then did you notice that your child has been talking a lot about his personal identity? Who am I? What is the relevance of living? What is the relevance of being happy? So, talking on those kinds of lives philosophy. So you have to take information from that information from the parents and the guardians. As students of psychiatric social work, you have to be, or even as professionals, we have to be very particular in taking history of the family dynamics and the communication style that is existing in the family. Are the parents getting divorced? Are they getting separated? Is there a lot of fight going on? What is the kind of communication that is imparted to the parent with each other and to the child? Is the child modeling any of the behavior of the parents in the form of self-harm? All these intricate details you have to gather. It is sounding, difficult, but it is not impossible. It may take, during the course of the history taking, you can call again the patient and take the history. And, in the meantime, in the same process, establish the rapport with the adolescent. While talking with the adolescent, if he has mentioned about any wound, किसी चोट के बारे में अगर उसने बताया है, any injury, then you have to ask that is it the first time he is doing, or is it the second, or is it, a number of times has taken place. Then when was the first time he had indulged in self-harm behavior? Did he tell anybody? What kind of tool did he use? For example, I told you that the girl who had carved that intricate design, she had used a compass, and none of us could have suspected with the wound pattern that had been there on the wrist. So you have to also very delicately ask about the implement that the adolescent or the young adult is using. In fact, the very next question from the parent should be that any of the sharp implement, such as razor, blade, knife in the kitchen is frequently missing, then that is a warning sign, mind you. So you have to then ask about the wound. If the wound pattern is very bizarre, very odd, then you have to ask that what is the reason behind this kind of a wound pattern? Is there a story behind it? Has the child seen somebody doing it and is now modeling it on himself? So all these intricate questions need to be probed and asked. You have to be a patient listener and always avoid being judgmental. Do not wear a look of shock or doubt, kind of an expression on your face, because then the adolescent would feel that, inhe bataएं या नहीं बताएं. The moment this kind of a thought enters in the mind of the adolescent, that she is looking she's looking judgmentally at me. So should I tell her about more about myself? No, I don't think so. So, that child might not come again in your session, and you might lose him or her, and you might lose the opportunity of, working with a wonderful case. So you have to be avoiding to be judgmental. During the course of the history, avoid using the word why, because at that moment of time, the adolescent felt that harming oneself was the best option available, because he was not having any other option available to, calm down himself or to come out of the distress. So ask this question, ऐसा क्या हुआ कि आपने ये स्टेप उठाया? ऐसा क्या हो रहा था घर में कि तुम्हें लगा कि शायद अपने आप को नुकसान पहुंचाना एकमात्र ही उपाय था, एकमात्र ही solution available था? This gives a room for more information. The moment you ask, why did you do it? You are placing yourself in the same parameter, in the same periphery as his or her parents. So you have to ask open-ended questions, because each one of us are having different life stories to tell. Each one of us and each patient has a different reason to harm himself or herself. So before, taking the history, read little bit about the literature on the reasons as to why people harm themselves. The reasons are many. The more you see cases, the more reasons will come out. For example, many people will tell you that they are feeling lonely, empty in their life. There is a lot of frustration and dejection, and that is why they harm themselves. Many of them would feel that the situation was going out of my hands, and I felt I had to control it somehow. That's the reason why I harmed myself. Many would say, for example, there was a girl who was 24 years old and had come to me for psychological testing. And she told me in the first 10 minutes that she had consumed the prescribed medication. And after much talking, she told me that the first time that she had harmed herself was in standard 10th, when she got to know that her parents were getting divorced. While when she was at 24 age, when she had overdosed, her boyfriend had blocked her on WhatsApp. So now you can see the common thread, the relationship dynamics that was lurking in both the episodes of self-harm. So even the lack of attachment and relationship dynamics, that also leads to self-harm. The perception of a secure, insecure attachment figure, the lack of, a positive feeling towards the attachment figure, the fear that somebody would leave me in the middle of a relationship. We often find this chief complaint in people who are having borderline personality traits. They then, the next step is, not always, but then they do harm themselves so that the other person doesn't abandon them, doesn't leave them in the middle of their life. So the reasons are many. Now, there is a wonderful article by Matthew Nock in 2010, and he has written a wonderful article on the functions that serve by harming oneself. So there are 4 functions. Now, if you can write it down, you can write. Now, these functions work in 2 directions. One is the positive or the negative reinforcement that the individual is gaining, and the other direction is the interpersonal and the intrapersonal. Interpersonal, the adolescent and the family members or his school friends. Intrapersonal, the adolescent himself with his own dynamics. So, whether the self-harm behavior is serving a positive interpersonal reinforcement. For example, the girl who harmed herself because she got to know that her parents were getting divorced, was it a plea that they shouldn't get divorced and they should stick together as a family? That you have to find out by analyzing the functions of the self-harm behavior. Lot of fights are going on in the family. My harming myself, critically, can the fights be ended? Can my parents stop fighting with each other? Can I be stopped being bullied at school if I start, carving my hands fully? So will my batchmates then stop bullying me? So what kind of function is being served by the self-harm that needs to be explored? I'm feeling that I lost my job and I have very little money left in hand, and seems as if, time is slipping away. And I felt as if I should pick up the knife and, cut my wrist. So is that moment of self-harm, is it serving an intrapersonal positive or negative reinforcement? After harming myself, did I feel better? Did I feel that, no, okay, I've lost my job, but okay, I can do something about it? So every person has a different reason assigned to self-harm. In fact, I have noticed that each episode has a different reason attached. But you have to find out, as a professional, you have to find out the common threads in connecting the each episodes. A number of hypotheses and models are existing in our vast psychiatry literature that will help you in understanding this concept. I'll very briefly describe it so that you can keep it in mind whenever you are talking with a person who is harming themselves. One is social learning hypothesis. Now, many a times we learn a lot of things by observing. For example, how should we speak when we are in a party? How should we interact when we are in a meeting? How should we, dress up when we are in an online meeting? So all this we are observing. But for a person who is harming himself, he might also be observing this behavior. Maybe his classmates, his very best friend, is trying to cope with his negative emotions by harming himself. So according to the social learning hypothesis, the individual learns by modeling. According to the social signaling hypothesis, now in social signaling hypothesis, the individual is tending and indulging in self-harm behavior by, why? Because he wants to indicate his distress and agony through the very act of self-harm behavior. So that is considered as social signaling hypothesis. Now, there was a case who got to know that she had been adopted and adopted by her very own extended family members. And it was very distressing for her, the agony. And then she started, she was brilliant, very attractive, vivacious female, excellent professionally. but she started harming herself as a indicator of her agony to her family members. That why wasn't she told that she was adopted when she was meeting her parents also, once in a year? Why wasn't she told that the uncle and auntie whom she used to meet once in a year were her real parents? Now that agony was very, very disturbing, but crying it out was not, acceptable. So according to the social signaling hypothesis, people tend to harm themselves and give it as a cue, give it as a signal to the other family members about their distress. Then another is implicit attitude hypothesis. Now, what is implicit attitude hypothesis? Now, for example, me having the temperament that I carry, if I am stressed, if I am tensed about something, I have a temperament of talking it out, be it with my spouse, be it with my parents, or with my mother-in-law. So or with my siblings, I have that temperament. But people who are having implicit, attitude, they might choose the very option of self-harm behavior because of their enduring personality traits, because of their personality characteristics of, emotional dysregulation, सेंसिटिविटी टू क्रिटिसिज्म. जरा सा किसी ने कुछ कह दिया तो तुरंत उस बात पर बिल्कुल भड़क गए और फिर अपने आप को बिल्कुल अकेला कर लिए और अपने आप को हार्म करने लगे. सो what are our enduring personality characteristics? That also affects our choice of, or our decision of choosing the self-harm behavior. Another hypothesis is still under research, as I used to read until last year when I used to present papers in the conference on this topic. There is a hypothesis named as pain analgesia hypothesis, where in fact, patients tell that ma'am, वो आप समझ नहीं पाइएगा कि वो psychological pain कितना है. तो हम कितना भी अपने आप को काट लें, जला लें सिगरेट से, वो हमको उससे फर्क नहीं पड़ता है, क्योंकि मन में इतनी ज्यादा दुविधा है, मन में इतना ज्यादा अंतर्द्वंद चल रहा है कि हमको पता ही नहीं चलता है कि हम इतने नोकीले चीज से अपने आप को हम काटे हैं या हम एकदम गरम सिगरेट से अपने को जलाए हैं, क्योंकि हम उस बात से उस समय इतना परेशान थे. So what is happening? The psychological pain, overpowers the physical pain that the person experiences. So the hypothesis and the theories are many. A good history, a patient listening is very, very essential when you are talking with a client who is harming himself. Now that you have a fair enough idea as to how to take the history, what points you should ask from the patient as well as from the parent and the guardian, what could have led up to the self-harm behavior, then starts the process of the talking therapy. Now, as a professional, I have learned from my seniors and my colleagues that you have to give time to the individual to tell his story, to tell why he chose this mechanism. So, as I said earlier, avoid being judgmental, avoid all talks of moral values and jargons. You will lose away your client, and you will also lose away the opportunity of learning. So avoid being judgmental, avoid wearing the look of being judgmental and of being shocked. The client is going to run away. Next, after the client feels settled and feels that it is a safe place where he can divulge his life story, then you can begin. Take him to that moment when he had harmed himself. Ask him, was there any other way by which you could have handled that very situation? What could have what you could have done at that very moment other than harming yourself. If you say that don't harm yourself, then it is quite unrealistic, because the person at that moment of time feels that self harm is the best and the most important coping mechanism. So you have to give an alternative healthy coping mechanism. Then only the self harm can go out of the life, the scenes of the life. So you can ask an open ended question कि उस समय जब तुमने चाकू उठाया उस समय तुम क्या कर सकते थे? तुम्हें जब पता चला कि उसने तुम्हें व्हाट्सएप पे ब्लॉक कर दिया है, मैं समझ रही हूं कि वो बहुत ज्यादा एक डिस्ट्रेसिंग, एक एगोनाइजिंग फीलिंग रहा होगा कि अब वो तुमसे बात नहीं कर पाएगा, लेकिन क्या वही एक रास्ता था अपने आप को नुकसान पहुंचाने का? तुम और क्या उस समय कर सकती थी या कर सकते थे जिससे कि तुमको शांति मिलती? तो you have to ask the alternative way of reacting at that very moment. Then you should have some basic knowledge about negative automatic thoughts and cognitive distortions. There are a number of cognitive distortions and negative automatic thoughts that lead up to self-harm behavior. Many a times we have seen that children carve failure, shame on their wrist because they have been bullied or critically criticized because of their poor academic performance, either in the class or back home or both. So, you have to be then start exploring the triggers. If the trigger, for example, is frequent fights among the parents, then you have to rope in the parents in the therapy, and you have to then tell them that, see, your fights and your dynamics with each other is serving as a trigger to the self-harm behavior. So then the parents also need to be counseled regarding the trigger. Then the adolescent has to learn the varying triggers and the situation which leads to the self-harm behavior. So if you land up in a similar situation again, then how should you react? What are the other better ways of reacting and handling that situation? Then another is that people who harm themselves, they often complain about feeling intense emotions. And mind you, all these emotions are, kind of bottled up in their heart and in their mind. So they should learn as to how to vent out these emotions. Ask them कि कितना बुरा लग रहा था, क्या इतना इस अगर बाकी और सिचुएशन में भी जब तुमने क्या तुम्हें ब्लॉक किया गया था तब भी क्या तुम इस तरीके से ही फील की थी या बिहेव की थी? So if he answers no, then how did you handle that very moment in the past? Can you replicate it in the present moment? So the emotions, then the individual would begin, describing the emotion. Take him back again to the cognitions that are attached with the emotions. Make him learn that what kind of thoughts that are lurking in your but yes, you can control the way you are looking at the situation. For example, post-lockdown, a 26-year-old female was referred to me with, depressive symptoms. In the third session, when she entered my room, and it was quite hot that day, and she was wearing a full-sleeved top. And then in the middle of the session, she said that, ma'am, I want to show you something. And then she unrolled, and there was a huge burn mark. And then she divulged that I think I had made a mistake of divulging my password to my boyfriend, and now he is accessing my Facebook and Instagram, and I'm really very petrified. Now that situation was overwhelming for her. So then it was discussed that are there ways of changing the password, changing the settings? Do you feel that you have to be cautious, and a limit setting needs to be done in relationship. So many a times each episode of self harm has a lot of periphery, branches evolving that you have to take up in the session, so that the individual understands that if he starts looking at the situation, if he tries to alter the way he is perceiving the situation, maybe then the situation would be more under his or her control. Uh, then there are a number of self soothing tips. For example, if you are having that strong urge of harming yourself, rub ice on your wrist, carry a red marker pen and mark lines on your wrist. But then down the line, I have always felt that these, instead of telling the client about the self-soothing tips, it is always very important to go behind the why behind the self-harm behavior, so that the intensity and the severity of self-harm behavior reduces with time, and the person then learns better ways of coping. Another important thing is as well, gradually reduce. So the intensity of the emotion will never remain the same. That you can explain to the individual. So this very moment will pass away. So if you can, you can identify your emotion, but you don't need to act on your emotion. So in turn, you are also, hinting towards working on the impulse behavior, and also explaining to him as to how the emotions can be regulated. When I work with my clients, I take an eclectic approach. I give time so that I can understand why the individual has come to me, and why is he telling me that he has harmed himself or herself. There has to be some reason. So then you have to give enough room so that the individual then tells his or her story patiently to you. And then, you can then overlap the functions, the reasons, and then with a conceptual model, a framework, you can write it down, and you can then discuss with the patient that, taking the example of your previous episode, these were the triggers. It seems as if the triggers are similar in this episode also. And as a clinician, I feel the parents and the guardians need to sit in this session also, in order to understand that why you had harmed yourself. If the adolescent and the adult is willing to allow the parents to enter the session, but they do. It is not that. If you confidently explore the history, people will tell you their dilemma and their story. Then gradually you can work on it. Now, many, at times, you can also become a ploy, if the patient is very manipulative and is seeking attention. So the same mechanism might be employed onto you also, kind of a threatening that if you don't pick up my call, I'm going to cut my wrist, I'm going to do this, I'm going to do that. So it is very important that you analyze the personality traits, the characteristics of the individual, and be cautious and alert from the very beginning. If you find that the adolescent is manipulative, or he or she is manipulating the self-harm behavior and avoiding the therapy session. So in self-harm is such an interesting concept that what function one is using and abusing, that takes time to analyze. But while you are talking, you have to talk on the negative automatic thoughts, try to correlate it with the intense emotions, try to talk about riding the wave as to how to handle the intense emotions. Make the patient learn to challenge the validity of one's negative automatic thoughts. क्या ऐसा सोचना क्या सही है? किस तरीके से तुम और सोच सकती हो? इसका और क्या सॉल्यूशन हो सकता है? So, if the person is describing a problem, then ask that by resorting to self-harm and fixing the problem in one shot, and it is not happening. So what are the options available in your hand? Can you make a list of the issues in your life that is in your hand and those that are not in your hand? Parents have decided for going for the ultimate, dissolution of marriage, of divorce. Is it in your hands? What can you do? Many a times the children blame themselves that, no, I think I was the reason. But then, ऐसा क्या हो रहा है कि तुम अपने आप को reason ये कर रही हो? So, the negative automatic thought of labeling. So it is very important that you should have, sufficient knowledge about cognitive distortion and the approach that it is our interpretation of our situation that leads to these kinds of behavior. So these things should be kept in mind while we are dealing with a self-harm behavior. And I would now like to end my talk with the point that I have learned that every person has a different life story. So there is no fixed questionnaire to, how to take the history. You have to use your own clinical skills and analytical skills in taking out the information from the client and then helping him resolve his or her own conflicts. Thank you. With this, I would like Manisha ma'am and Nazish Fatima to take over the session. Thank you.
Thank you, ma'am. The forum is open for question and answer session, and here in the chat box we have some questions that Benny Verghese want to know that where we can see self-harming behavior in Bible.
Okay, I had quoted it from the Knox article. It was there. I can't tell the testament or the chapter. That I have read it up in an article by Knox, okay. Matthew N. Knox in 2000.
And there is one question from Department of PSW RINPAS from the YouTube. What if the adolescent does not want to include the parents in the therapy?
Okay, there are times when, when we write self-harm behavior in the psychological report and the adolescents rarely react, but then you have to then explain, you have to give time to the adolescent that, this is a problem, because many a times they don't see it as a problem. They see it as a coping mechanism. So give them time when, because they, you have to understand that why they don't want the parents to be included in the therapy, because they'll again start their jargon talks. So, first gain confidence of the adolescents, and you don't need to rush the parents into the therapy. Yes, parents alone can be made to understand. They should be given, full psychoeducation about the physical warning signs that I discussed, missing of the blades, missing of the sharp knives, missing of phenyl and harpic, mysteriously missing all the, nail cutter, etc. The psychological warning signs that I discussed in the early portion of the session. So these warning signs need to be told to the parents briefly. separately. And then when the time is correct, take the adolescent in confidence and then rope in the parents in the therapy session.
Okay, thank you, ma'am. I request Anju Gautam, ma'am, please switch off your camera. And in the chat box, Dr. Beni Varghese also want to directly interact with you.
Okay.
So, how do you say? She want to directly ask some questions to you.
Okay, okay. I'll see whether I am able to answer it or not.
Okay, Beni ma'am, you can ask. She's not here.
No, he's there.
He's here. Yeah, he is.
There is one comment. I will like to take it up. It is very
He's
important.
not unmuted himself. I think Dr. Beni is speaking, but he has not unmuted himself. So if he can unmute himself. You, Nazish, ask him to unmute.
Yeah, Dr. Beni, please unmute your option so we can hear you. I am blocked. He says that I am blocked.
Okay, if we he has to unmute himself. How can he be blocked? I think he needs to unmute.
Sir, there is an unmute option in your screen right now in your page.
If we have some other question, by the time, Vikas, if you can see what's the matter.
Ma'am, there is one very important comment by Dr. Beni only. The observations stated are the same with Indian students in Indian school across Sultanate of Oman, but it was observed as contagious. Now, even in 2016, I had a case where I was working previously. The girl came, and the moment she sat, the very 10 minutes she started stating her self-harm behavior. The next day, her best friend came in the OPD, and she also stated the same pattern of self-harm behavior.
Okay.
So both of them were mimicking each other. So, more than the, then, we were clueless that how to take both of these girls into therapy. So we decided that, two of us would be talking with them separately, because there were chances that they were doing self-harm in order to avoid exams and go to the sick room, for a long period of time and evade the classes. So this observation is very important.
Yeah, there can be varied reasons.
Yes.
We need to explore that.
Yes.
हेलो विकास, हाँ वो क्या हुआ डॉक्टर बेनी का? ठीक. Okay. Any more questions? So it was a really very wonderful deliberation from Divya. If we are getting other questions, by the time we can have a discussion, because the things that you have said, that whenever we are taking an history and we are talking with a client, it's very essential that we be patient ourselves. Yeah. And be very tolerant in hearing them, so that they are able to come forth with their actual problems.
Yes.
Yeah, if we are very quick and making a judgmental, giving a clinical diagnosis immediately, then we'll miss the real hidden agenda behind that, right?
Yes,
It's
yes.
very important that we really give enough time to make them comfortable and come forth with their actual reason behind it. That can be varied. Can be environmental factors or any other reasons can be there. Whether it can be from school level that the sir has Dr. Beni was talking about, you know? So it can be many other associated reasons. It's not only family factors, but can be other
Other.
related issues also that they are coming forth with these.
Yes. Like for
Uh,
example, if he or she is indulging in lot of mobile overuse,
yeah.
gaming, and the gaming part has been deleted, the app has been deleted. Now,
Yes,
what
yes.
else should be given? If you are taking away one thing, then you have to give another thing to the child.
Another, yeah, yeah. I think
Yeah.
Dr. Beni has joined and he
I would
can.
like to add.
Yes, Dr. Beni, can you come? Again, there is some issue. Dr. Beni, can you unmute yourself? Just unmute yourself. Yeah,
Can you hear me?
Yes.
yes.
Yes. Now, what Divya Prasad ma'am was saying exactly correct what I am facing here with my students.
Okay.
So that is true. But one second. Major problem which I am facing, why it is contagious. See, many girl students, they are transferring this disease condition from one to one. Now, if you find a child or a group of child, they will be either friends or cousins, etc., or they are going to same place.
Yes.
And 90% of them are using full sleeve shirts, uniforms, so that nobody can see it.
See.
And instruments used are same thing, compass, blade, or even nail cutter pickings.
Yes.
And they are shaping, and even sometimes we can find alphabets on the physical. Now, my question is it necessary to have a medication? I find without medication, psychiatric interventions, I am not able to get proper result. So 99% after few therapies, to continue itself, I am sending them to psychiatrists for a medication. Then I am continuing the session, then I am getting the result. See, I am a naturopathy physician too. I have done my PhD on naturopathy on mental health. But in this case, I find really challenging with these students. They are not ready to abide by any other laws. Simple methodology only they are interested in. Now, according to your experience, should we take a this one assistance or any other ideas? What do you think about?
See, it depends on what kind of self-harm the child is indulging. The one that I talked about, the carving on the wrist. Now, that child was very guarded. It took me several sessions to understand that she was doing it with the compass. And at the same time, muttering to self, smiling to self, and there was underlying psychotic features. Then I had to refer her to the psychiatrist because there was a family history also. But there are times when alone, the talking, the cognitive behavior therapy works. But if there are enduring personality characteristics, if there is very intense emotional outbursts, then yes, I do refer to the psychiatrist, and the patient does come and attend the prescribed therapy sessions that are there. Because if one is listening to them, one doesn't need to jump and start asking the why behind the self-harm. That is very important, that I learned. If one is just listening and understanding that why the individual, because while talking, you will get the information of the why. Then the children will come to you. But the moment we start modeling or we start behaving as the parental figure, the authority figure, then the adolescents will not cooperate in the therapy. So as my experience says, I do refer to the psychiatrist, and then we, after every session, we discuss also that this was after a lot of number of months, the girl divulged that she has harmed herself recently. So did she tell you when she came to you? Then the female psychiatrist says that yes, and I think do you feel a repeat psychological assessment is needed? So that way things are done.
The psychologist usually doesn't understand the need of medication. They are asking what is the problem behind it.
Yeah.
That's a common question. We have to explain to them.
Yes.
Now, here, our major challenge, which we are saying, they are not feeling any pain. Instead of they are saying when they harm themselves, they are feeling some sort of burning sensation. And which is forcing them to again do the same.
Yes.
So, what sort of physiological craving it is?
You have to then, that is why I said that before diving into self-harm work, you should have a sufficient knowledge about the cognitive distortions that are lurking behind. Because all these negative automatic thoughts also have a correlation with the feeling that I am not feeling that physical pain. तो you have to ask कि ऐसा उस समय क्या हो रहा था कि तुम्हें कोई पेन नहीं महसूस हुआ, लेकिन तुम at the same time you were distressed. So the negative automatic thoughts will automatically come out, and then you can correlate with that pain analgesia hypothesis, or even with the social signaling hypothesis.
And apart from that, can secondary gains maybe one of the reasons?
Yes, ma'am. It is, ma'am. I told you there was one patient who used to harm herself in order to avoid the therapy. The parents were understanding. She was also understanding. But when she started understanding that we are absolutely knowing as to why she is harming herself, then she started avoiding. So that secondary gain she was getting.
Yeah.
She was getting.
So we need to understand one very important thing apart from this, that what are the secondary gains a client is getting. It is not only therapeutic, family attentions, there must be some other reasons.
Yes. Like ma'am, I told you, the mention that the girl got to know at the age of 24 that she was adopted. And she would meet her real parents as uncle and auntie once in a year. So you can very well imagine the dilemma that she was experiencing, that why she was not told.
Yeah.
And then she started harming herself. So that was kind of a, signaling her distress. So you have to be mindful about the cues that the individual is giving you in the therapy session. I mean, this is what I have learned from my cases.
Yes.
I want to further exceed. Many of the school refusing cases are having the prior history of self-harming.
Okay.
I think it can be also added to, because there are many students who are getting addicted to internet, everything, and they make day as night, night to dusk, not now this situation, previous situations.
Yes.
And we were finding that these students had a self-harming behavior in the beginning, and they have started to school refusals.
Yeah. I forgot to mention another point, that we as professionals also should ask that whether the adolescent is indulging in reading dark literature on the internet. There are a number of dark literature available where they encourage self-harm. There are a number of music videos on YouTube. The lyrics, they will not listen to the music. but they will analyze the lyrics and they will come to you with the entire, song downloaded, and they'll tell
Even
you
though-
that, ma'am, look at this song, it is resembling my agony. So we as professionals also should read about it. Then only, we can understand that why they are correlating the dark literature with the Self-Injury Act.
Sure.
Thank you.
Thank you.
Any more questions?
There is no question in the chat box. And
Anyone from the participant would like to come forth for any discussion or their experience in their professional year? Yeah, Shampa is there.
Yeah, I am here.
Yeah,
I
Shampa.
want to, my experience I would like to tell in this forum. I have been working in NIBHAS, Child and Adolescent Clinic, for last 10 years. So from my experience, I would like to add one thing, that is compared to the population of children and adolescents who are staying in the family, a number of children who are staying in children's home are more prone to do self-harm behavior.
Yeah.
And children from children's home, they are getting referral to come to IVAS for treatment. And self-harm behavior, in case of this sort of self-harm behavior, medication is also required. And we have seen it is learned behavior also. A group of adolescents are staying together. They very quickly learn from each other how to do this self-harm behavior, as Dr. Dibba was telling from her experience.
Yeah.
So the various stimulus is necessary to give to them to dysregulate their emotion through therapy, whatever possible in the changing in the structural phenomena where they are staying. This actually I want to add.
Thank you. Very welcome. Thank you so much.
And I have one question, ma'am.
Yes.
What will be the parents' approach in this behavior? Because whether they are overprotective to the child and or they are not caring for the child because they say that ये तो ऐसे करता ही रहता है. So what will be the parent approach in this?
At that point, psychoeducation has a very important role in order to the parents to understand that ये कोई ऐसे ही problem नहीं है. This is an actual serious problem behavior which will continue if not treated in later adulthood. So according to me, a good informative psychoeducation needs to be imparted to the parents every now and then, because if the self-harm is not stopping, then it means then the approach of the therapy needs to be changed. But for the parents, they have to understand that it is an absolute serious problem which needs immediate attention.
Okay. Thank you.
And ma'am, one more thing, there are times when the parental figures are also harming themselves.
Yes, yes.
So if the father is an alcoholic and he's beating the mother in turn is not eating or secretly cutting herself. Children are very observant.
Doing all these things, no? The learned behavior.
Yes. Yeah. So that is one. Even the parents' personality needs to be taken into account when we are starting the therapy. Yeah.
A detailed family history is definitely needed.
Yes.
So it was very enlightening. They were very informative, and I think the way the participants have come forth, it means that yes, it was fruitful.
Thank you, ma'am.
Has been sure served.
Thank you, ma'am.
So if we don't have any more questions, Aziz, we can conclude the session.
Yeah, thank you, ma'am, for your interesting
Thank
presentation.
you.
And she beautifully described that what is the pain and motive behind this behavior, and the analysis of the wound and cut, and any other type of injury the person have. And she also explained the role of how to deal, how as a therapist we deal with this problem, because we have to take non-judgmental attitude. We should have the good listener, and we already ask, we always ask the open-ended question to the patient. So I think she covered all of the areas, and she also discussed about the live examples she also seen in her clinic. And now we have no question and no other question. And we also give thanks to our seniors, Govinder sir, Upendra sir, and Sampa ma'am, for your valuable contribution and questions. And finally, uh, as a finally we came to the end of the session. And I would like to huge thanks to our Manisha ma'am, that she gave us our experience, lot of experience. And I think that this experience is beneficial in our clinical and clinical field. And thank you, Divya ma'am, for your valuable time. And we have a lot more series in this webinar. And we will meet you in the next. So thank you very
Thank
much,
you.
audience.
Thank
And
you.
thank you all the participating members and audience for the active participation, and a good uh, question and participation. Thank you very much.